Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Endometriosis, organized by Pinnacle News Series. And today's episode is 15 in association with Agra, Darbhanga, Ajmer, OB societies, and also OGSS. It's my privilege to introduce. So let us start the webinar with God's blessings. So it's my privilege to introduce the MOCs of today's webinar, Dr. Madhumita Arun Kartik ma'am. Ma'am is consultant obstetrician and gynecologist from Salem. I welcome you, ma'am.
Thank you so much, Sahiti.
Yes. It's my privilege to introduce the other MOC, Dr. T. Radhika Gauri ma'am. Ma'am is specialist consultant in OBG and clinical lead from Pinnacle. I welcome you, ma'am, and I hand over the session to the conveners.
Yeah. Thank you so much, Sahiti. So it is my pleasure to introduce the convener for today. Can I have ma'am's slide? Extremely grateful to Professor Dr. Sampath Kumari ma'am, who has brought about this Pinnacle News webinar series, which unites all the four corners of our country. And ma'am is a professor in H of obstetric and gynecology at Sri Muthukumaran Medical College and Hospital. She was a past vice president of FOXY. She's a Senate member of Tamil Nadu Dr. MGR Medical University and also the national corresponding editor of Jogi, founder secretary of TN.
Thank you, Madhumita.
Yes, ma'am.
Thank you. We'll start the program.
Yes.
Thank you, Madhumita. I welcome you all for this Pinnacle Series 15. As Madhumita has mentioned, we have Pinnacle News from 4 societies. That is from North, East, West and South. Today we have our own Aksi and Ajmer and Darbhanga and Agra. Sultanpur also we have added. Now, I welcome all the president and secretaries of the 4 societies, the faculties and the delegates. And we have the chief guest as Dr. Epsiba Kribamani madam. Can I have the CV of Dr. Epsiba madam? Epsiba Kribamani madam is past president of our own Oxy and past president of Chennai Menopause Society, IMS Chennai chapter and joint treasurer of IMS now and received 2 consecutive year Best Society Award. And she has awarded many awards. She has given only little, I think, here. She has the PhD and she is a PhD guide for SRMC, Savita and SRM. And she had many publications. And her field of interest is much is with the menopause. And for colposcopy also, she has made some handmade colpo. Now I welcome Dr. Epsiba madam for her wishes to the webinar. Epsiba madam.
Thank you. Am I audible? Am I
Yes.
audible?
Yes, ma'am. Yes, ma'am. Little voice low, ma'am.
Little not clear, but you're audible.
Yeah, at the outset, I thank the organizers. A
Siva
special
madam,
word
konja
of
sound
thank.
பேசுறீங்களா?
Yes, at the outset, I thank the organizers and a special word of thanks to Dr. Sampath for inviting me to grace the occasion. It's my privilege to say a few words. Already, as mentioned by Dr. Sampath Kumari, the word pinnacle means it's a point of converge, and it means the highest point attained or attainable. So it is the point of converge. She has nicely designed that word, the north, east, west, and south. And she has taken so much effort to converge Obstetric Gynecology Society of Southern India with Agra, Darbhanga, Ajmer, and Kanpur. And the program is well curated. And the topic chosen today is luteal phase defect and the recurrent pregnancy loss is going to be very, very useful for our day-to-day practice. And I wish all success today's CME and for future Pinnacle news series for all the success. And I wish a special wish to Dr. Sampath Kumari, your president candidate of 2026. Thank you so much for the opportunity. Thank you so much.
Thank you so much, madam. Thank you. Thank you so much, madam. Hope everything should go very well. Yes, thank you, madam, for the wishes. And now we go to the guest of honor, Dr. Kumudini Jha. She is an ex-HOD and she is the president of Darbhanga Society and past clinical secretary of Darbhanga. And she has many paper presentation in national and international conference, faculty in Foxy conferences. Now I welcome Dr. Kumudini Jha for her wishes for this webinar. Dr. Kumudini madam.
Thank you so much, Sampath madam, for having me
Kumudini
here
madam,
on
1
this.
minute. Kumudini madam, 1 minute. I want to tell one thing about Dr. Siva madam. She will be always with a flower on the lady. Now also she is having the rose flower. Even in the
Right.
international conferences, we can say her and see her with the rose flower. That is her speciality. She is
And
an extraordinary one.
One more
Okay,
thing,
madam.
Sambat, I want to add about madam. Madam is the first DSc holder, ma'am. She is the DSc holder. She is a PhD and the DSc holder of Southern India, ma'am. So
Yes,
we are very
Southern
much
India,
honored
definitely.
to have a DSc with us with so much of knowledge and teaching one, ma'am. That way,
Definitely.
Depsi madam is a great person.
Thank you, Jayarani. Yes, Kumudini madam.
Thank you very much, Dr. Sampath, and the whole Pinnacle team for having me here on this prestigious platform of Pinnacle. And I have been following for quite some time. It's very informative. And today also there are two interesting topics. One is on the luteal phase defect. Actually, it is very intriguing, and some people do not even consider this as an entity. But we do find cases where the follicle grows up till 25 mm and it doesn't rupture. So it's quite perplexing then. So we are going to have to see the importance of what is the progesterone levels, how it can guide us, and more about the LPD, how to manage it from a learned speaker. And the other topic, recurrent pregnancy loss, is again a frustrating situation for all of us. We all face it day in and out. You do all the investigations, all of them are negative. The routine investigation, blood group is normal. The blood sugar, APLA, everything is normal. Endocrinologically also, the thyroid, prolactin, nothing is wrong. But still you don't see that the patient conceives and she has recurrent pregnancy loss. So there are many molecules. The molecular medicine is going to come up in a big way. And we all know that right from a position to adhesion to embedding in the decidua, there are many factors like the lac, the glycolidin, and the TH1 and TH2 balance. Then there is the TREG cells, and all these are macrophages. All of them help in embedding of the trophoblast. And when don't find any causes, then we go over to the autoimmune causes, and then you go over to the inflammatory markers, like especially the uterine NK cells, which is now coming up, but it is not freely available in the market. So what is the role of intralipids, IVIGI, and all that we are going to hear from our panelists. And it is not a surprise that baby aborts, but it is a surprise that it continues because it is an allograft. And how the immunocompromised state helps it we are going to see in the panel discussion. Thank you so much, ma'am, for having me here.
Thank you, Dr. Kumudini. I think Dr. Rama is there. Dr. Rama? Or else you can put the CV of Dr. Manju Verma. Jayanani, you can introduce Dr. Manju Verma, madam.
Madam, we welcome you, madam. I'm Dr. Jairani
Yes.
Kamraj.
Yeah.
Can you hear me, Sampath?
Yeah, everybody.
Yes, ma'am.
Yes,
Everybody
introduce.
here.
It gives me a great pleasure and honor and a very, very special day because we have with us very many eminent people from Foxy and Menopause Society. We have our chief guest, Dr. Um, Hepzibah, madam. Madam, thank you so much. And we have the guest of honors, Dr. Kumudini Jha, the president, and also Madam Dr. Manju Verma, who is the guest of honor. And we are really privileged and honored to have you here, madam. Thank you for accepting our invite and being here to grace your presence as a guest of honor, madam. Madam is the past president of the UP chapter of OBGYN, and she is the certificate honored in medicine, and she's a gold medal of PC Band gold medalist.
I think it is enough. Isn't it, Sampath? This is enough.
No, ma'am. We need to introduce you, ma'am. She has more than 100 scientific papers in national and international journals and made a lot of orations, guest lectures in national and international and state level conferences. And she is the technical expert for the Public Service Commission of UP and MP, an examiner in state and other universities. And madam is the prestigious President Gold Medal she has got, which is really a proudful moment for all our Foxians. And she has the Prasanna Pratra and silver medal in 86 and 87 and 88 for her meritorious family welfare work and silver medal for the work in the rural family welfare camps, which is really a very, very, a wonderful thing that we look upon. When we are postgraduates, we used to see so much of family welfare work being done in the rural area, and it's a real honor to have you, madam, here. And madam is a very pioneer of teachers and trained a lot of postgraduates. Madam, we welcome you and we have very much blessed to have you here, ma'am. Over to you for your words of wisdom, madam.
Thank you, Jairani, for such kind words. Only thing I would say that this is Pinnacle 5, you are coming to the episode 15, and it has given so much of knowledge to people, and that is why I say this is something very prestigious webinar that you are conducting. So I would like to welcome all the presidents and all the societies secretaries to this, and this is a special webinar because this is corpus luteum function is one thing which is very, very common. Everybody is dealing with it. And to have a scientific approach to corpus luteum defect function is very, very important because more than 4% of fertile population is having corpus luteum defect, as well as the incidence may be much more as far as the recurrent pregnancy loss is concerned, may reach up to 35%, or maybe in infertile patients, really it can be as much as 13%. So that is why I say this is scientific approach, because it's really difficult to really coin down or say that it is corpus luteum defect, because you don't have so many investigations or ultrasound findings. But so I think this is going to be a very, very important and webinar, as well as the panel discussion is also very good on case based. So I would like to Jairani, Povi, and other people who are contesting, especially Richa, I think is there. If I'm not, anybody else, I don't know the name, but these two people I know the name, and they are, I wish them success, a thumping success. That is what I can say. Wish and pray for that, for all the people who are contesting now for the ICOG Council. Thank you very much.
Thank you, ma'am. Thank
you. Thank you, Dr. Manju. Yes, thank you. Rama madam is there, huh? I think she's not there.
No, ma'am.
Dr. Rama, are you there?
No, madam was there earlier. She was there.
She was there, ma'am.
She was there.
She was there. If Rama madam is not there, we will start with scientific session.
Yes, ma'am. I'll call her in the
Dr. Rama?
Ma'am had joined.
Not joined. Anyway, Madhumita, you start with the scientific session.
Yes.
Whenever she is joining, we can
Yes, ma'am. So
Thank you.
moving on to the first session, we have a very informative talk on luteal phase defect, and it's my privilege to introduce our chairperson. Can I have the CV slide, Sahiti? Dr. Richa Singh, who's the president of Agra Obstetric and Gynecological Society. She's the professor and head of the department of OG in SN Medical College, Agra. And she's also the vice president of ISOPARB in Agra and also scientific advisor of Agra Menopause Society. She's a PG teacher of more than 24 years experience, and she's also has conducted numerous CME programs and skill-based trainings by workshops and webinars. And she's also promoted digital learning resources through her supportive research and collaborative learning. Welcome, ma'am.
Thank you.
So-
Thank you. And I would like to thank Manju ma'am also for her blessings. Thank you, ma'am.
So we have our first speaker. Can you introduce our speaker, ma'am?
Yeah,
Richa.
so it's a pleasure for me to chair this talk on such an important thing, luteal phase defect. And we have the speaker with us is Dr. Meena Mahalingam. She is Associate Professor in Obs and Gynae at Chengalputta Medical College. And she is also the Secretary of Obs and Gynae Society, Co-Chair Urogynae Society. She has received special trainings in urogynae, microsurgery, and endoscopy, and clinical experience of 23 years in a tertiary care teaching institute. She's a master trainer of EMOC, and she has received many scholarships. She has many publications to her credit. So now I think without more time in between, we will begin with the talk from Dr. Meena on this important topic of luteal phase defect.
Good evening, everyone. Thank you, Sampath Kumari madam and team for having given to speak on luteal phase defect. Am I audible? Richa ma'am, thank you for the kind
Yes,
introduction.
yes,
So, as we all know, luteal phase defect we would discuss in based on definition, the etiology, the diagnosis, and the treatment part of it. Next. So LPD historically considered as a cause of infertility and recurrent pregnancy loss. So it was first described in 1949 by George Anna Seeger Jones, and still now it remains controversial. That is in 2025, whether it is real, rare, or overdiagnosed. Next. Chitrakala. So the prevalence and demographics. So any topic we need to know how much is the prevalence.
इंजेक्शन के बाद डाली थी तो इंजेक्शन लगा के 1 महीना और टेबलेट भी खानी थी तो आयरन कुछ तो जाता
Sahiti,
Chitrakala, can you mute everyone?
हाँ 2-3 दिन बाद ले लेना
Chitrakala, can you mute everyone? Madhumita? Yeah.
Yes,
So
ma'am.
prevalence, yeah, 3 to 10% of all the women, and 25 to 40% of women with infertility, and 30 to 60% of women with recurrent pregnancy loss. In India, the luteal phase defect is underdiagnosed due to limited awareness and diagnostic resources, particularly in rural areas where fertility challenges are often attributed to other causes. So the high-risk groups are mainly for luteal phase defect, women with polycystic ovarian syndrome, athletes with low body fat percentage, and women with hypothalamic amenorrhea, thyroid dysfunction, women experiencing high psychological stress, those with a history of endometriosis, women approaching perimenopause, and individuals with eating disorders. Next. So we should know the physiology to understand the pathophysiology. As we all know, the corpus luteum forms after ovulation and produces progesterone. Progesterone prepares the endometrium for implantation, maintaining early pregnancy. Typically, the duration of luteal phase is 12 to 14 days, as we all know. Next. Chitrakala. So physiology of normal luteal function. In unassisted cycles or unstimulated cycles, the corpus luteum progesterone is essential for early pregnancy until the placenta produces enough progesterone. Removal of the corpus luteum before placental competence causes pregnancy loss. And the average duration will be around 11 to 17 days. The progesterone hormone peaks 6 to 8 days after ovulation in non-pregnant cycles. Next. Progesterone secretion is pulsatile which is driven by the luteinizing hormone. The pulses are more marked in mid to late luteal phase with up to 8-fold fluctuations in 90-minute duration. Endometrial changes reflect the combined follicular phase estrogen and luteal phase estrogen and progesterone, which depend on the proper follicular development, ovulation, and corpus luteum function. After implantation, the progesterone secretion depends on the rising human chorionic gonadotropin. Inadequate human chorionic gonadotropin rise causes corpus luteum failure and progesterone decline. Next. So as we all know, starting from our physiology days about the ovarian histology and the endometrial histology, we all know in the initial 14 days, we have the follicular phase wherein the FSH increases, thereby increasing the hormone estradiol, which in turn causes an increase in the LH surge and ovulation, followed by an increase in the progesterone hormone in the luteal phase, along with estrogen. If there is a pregnancy, this corpus luteum continues and supports a pregnancy. And if there is no pregnancy, it becomes a degenerated corpus luteum. Next. So when he described, he called it as abnormal luteal phase or luteal hypoplasia or premature degeneration. This is mainly going to cause either infertility or recurrent pregnancy loss. The classical definition was luteal phase length less than or equal to 10 days. Alternate definitions were less than or equal to 11 days or less than or equal to 9 days. Biochemical definition is low integrated progesterone level across the luteal phase. We'll just see in the next few slides. Diagnosis mainly is clinical. Only required we do the biochemical testing. Next. So the implications, as we all know, infertility and pregnancy loss. The studies show there is a faster progesterone rise and higher mid-luteal estrogen and progesterone in conception cycles versus non-conception cycles. Early embryonic HCG affects mainly the mid-luteal hormone levels in conception cycle. Next. So apart from the infertility, first trimester loss, it also causes short cycle and premenstrual spotting, which can also occur in normal cycles. Evidence remains inconclusive on whether abnormal early loss in natural cycles. The leading to reduced luteal estrogen and progesterone.
Ma'am, your signal
Some
is
women also have a. Am I audible, Madhumita?
sometimes it's breaking, ma'am. Can you switch off your video so that
Madhumita?
the yes, ma'am. It's breaking in the middle, ma'am. Can you just switch off the video so that
Yeah.
yes,
Now,
ma'am. Yes, ma'am. Yes, ma'am.
Yeah, I've switched off the video. Is it okay
Yes,
now?
ma'am. Yes, ma'am. Yes, ma'am. Yes.
Some women also have endometrial progesterone resistance with defective tissue response despite adequate hormone levels. Next. Chitrakala. Next slide. Idiopathic LPD. It refers to luteal dysfunction without any identifiable disease. There is no clear serum progesterone threshold for natural cycles due to pulsatile secretion. Modeled cycles suggest 2.5 nanogram per ml may suffice for histologic abnormality, but 8 to 18 nanogram per ml may be needed for normal gene expression. Idiopathic LPD has not been conclusively proven to cause infertility. Next. Chitrakala. Conditions which can alter the luteal phase, like disruption of GnRH and LH pulsatility, which is mainly responsible for the progesterone increase, can also lead to LPD, like hypothalamic amenorrhea, eating disorders, PCOS, endometriosis, aging, 21-hydroxylase deficiency, thyroid dysfunction, hyperprolactinemia, ovarian stimulation, and ART. So thyroid and prolactin disorders, mainly they impair the GnRH secretion. Hypothyroidism can cause hyperprolactinemia via the release of thyrotropin releasing hormone. Next. Chitrakala. And also obesity. Obesity, as we all know, it reduces the fertility and increased pregnancy loss, which is linked to reduced LH pulse amplitude and decreased luteal progesterone metabolite excretion. Whenever there is an advanced reproductive age, also shows a decreased luteal progesterone and estradiol metabolites, but diminished ovarian reserve alone is not linked to luteal phase defect. Next. So how are we going to diagnose? As I already mentioned, the diagnosis is primarily clinical. Many clinical, biochemical, histologic tests have been proposed, but none is reliable, distinguishing from fertile from infertile women. The least invasive method, that is identifying the shortened luteal phase, is based on the menstrual cycle length. Moderately invasive methods like luteal phase length assessment via the basal body temperature charting or urinary LH surge detection kits may also be used. Next. Diagnosis for biochemical methods, either a single or serial serum progesterone measurements. Most invasive method will be the endometrial biopsy. Next. Chitrakala. Menstrual cycle length. So monitoring the basal body temperature or urinary LH surge helps confirm ovulation and luteal length. Average luteal length is 11 to 17 days. The short luteal length, less than 9 to 11 days from LH peak to menses. The definitions vary, complicating literature interpretation. Short luteal phases occur in non-infertile women. That is, it is seen in normal women in 13 to 18% of ovulatory cycles. The short luteal phase may reduce conception probability in the next month, but no reduction in the 12-month fecundity. Meaning to say that luteal length can only be measured in non-pregnant cycles, adding complexity to the diagnosis. Next. What about progesterone levels? Progesterone level, as I said, 6 to 8 days post-ovulation, there is an increase. That is more than 3 nanogram per ml indicates ovulation. But there is no threshold which defines the normal luteal function. Because it is secreted pulsatility in response to LH, the values range 5 to 40 nanogram per ml over short intervals, limiting single sample interpretation. In ovulatory cycles, less than 5 nanogram per ml occurs in 8.4% of the time, less than 10 nanogram per ml occurs in 31.3% of the time in fertile women. Corpus luteum function varies between cycles even in the same women. Next. We all know about this cycle. Next. Best proposed method, as I mentioned, the integrated luteal progesterone. What does it mean? Daily values should be summed up. Anything less than 80 nanogram per ml, lowest in 10% of the cycles, proposed. Alternatively, 3 values between the luteal days 5 to 9, totaling less than 30 nanogram per ml, 3 values. Both methods are impractical and unvalidated, so they are not reliable per se. Next. Next. So combined menstrual cycle length and mid-luteal progesterone testing. What is that called? It is the biocycle study. 8.9% of the cycles had luteal phase less than 10 days. That is called as clinical luteal phase defect. 8.4% had mid-luteal progesterone, which is less than 5 nanogram per ml. That is called biochemical luteal phase defect. Both these types have been linked to lower follicular estradiol, lower luteal estradiol, lower luteal progesterone, and lighter menses. Most women who have clinical luteal phase defect also had mid-luteal progesterone levels. So it is important we combine the luteal length along with the progesterone. Next. So this is a histological picture showing the endometrial biopsy. Next. So historically viewed as Novis has mentioned about endometrial biopsy in the earlier years. For histological dating, implantation involves many factors beyond histology like receptors, proteins, growth factors, cytokines, and pinopods. Single biopsy may not represent global endometrial maturation. RCTs, they show high variability up to 25% delayed maturation in fertile women. 49% in the mid-luteal, 35% in the late luteal biopsies are out of phase, that is with no difference between fertile and infertile women. Next. So we just can classify as early, mid, or late luteal phase. We cannot distinguish fertile from infertile women. Next. So concluding with endometrial biopsy and LPD. Histological endometrial dating is not valid for LPD diagnosis. Progestogen studies along with endometrial biopsy, that is normal histology seen with peak progestogen that is more than or equal to 2.5 nanogram per ml, but normal gene expression needs a progestogen more than 8 to 18 nanogram per ml. Next. Chitrakala next. Other markers and current status. Numerous biochemical, morphologic, and molecular markers proposed for endometrial receptivities. No marker validated in RCT to differentiate fertile versus infertile women. All the molecular receptivity assays remain experimental and not recommended. And they are not reproducible, and there is no gold standard for LPD diagnosis. Next. Role of progestogen measurement, endometrial biopsy, novel markers remain unestablished. And we do have certain tests which is not at all recommended. Next. So the proposed treatments, this is the main thing. If there is no clear diagnostic criteria, quality evidence for treatment is lacking. Many diagnosed cases may overlap with the normal fertile women. So first step, rule out other causes like hypothalamic dysfunction, thyroid dysfunction, and hyperprolactinemia and treat them. Next. So if no cause is found, empirical treatment not generally recommended due to poor evidence. The empirical goal, the treatment goal is to improve the ovulatory function, promote endometrial maturation, enhance receptivity for implantation, support early pregnancy development. Next. So for this, what is the treatment? This is the only main thing. Empirical approach which were tried are the supplemental luteal progestogen, progesterone with estrogen, or luteal HCG. Next. What is the role of progesterone? Progesterone is an essential hormone in the menstrual cycle and early pregnancy, which exerts many effects on the endometrium, orchestrating a finely tuned sequence of changes crucial for optimizing its receptivity to an embryo. This intricate process involves various structural and functional alterations within the endometrium. The decidual cells produce a range of factors, including growth factors, cytokines, which play pivotal roles in creating a welcoming milieu for embryo implantation. Next. Chitrakala. So the role of progestogen. Main thing is decellularization. Whenever we are giving progestogen, the endometrium undergoes complex decellularization process. During decellularization, the endometrial stromal cells transform into specialized decidual cells. This transformation is fundamental, creating a supporting environment well equipped to accommodate and nurture an implanted embryo. Uterine contractions. Progestogen is supposed to cause the endometrium quiescent, thereby prevents the regular uterine contractions. And also immune tolerance. It orchestrates an intricate dance with the immune system within the uterus. It promotes a unique state of immune tolerance conducive to embryo implantation. So the immunomodulatory function is pivotal as it prevents the immune system from recognizing the embryo as a foreign entity. Next. So the main treatment, this is the latest, that the dydrogesterone is given. It is a synthetic progestogen, has gained significant recognition for its pivotal role in managing luteal phase defects and addressing various reproductive conditions. Its mechanism of action is grounded in its distinctive pharmacological attributes, which distinguish from other progestogens, rendering it an attractive choice for optimizing luteal phase function and ultimately enhancing reproductive outcomes. Next. So it stands due to its structural similarity to the endogenous progesterone. It mimics the action. Thereby, this hormone maintains the uterine environment during the luteal phase. Unlike the other progestogen, it closely mirrors the molecular structure of natural progesterone. Similarity enables the dydrogesterone to interact with progesterone receptors selectively, specifically those involved in uterine function, while minimizing interaction with other hormonal pathways. Next. Chitrakala. So either it can be given oral or sublingual. The dose is 10 to 40 mg daily, or vaginal suppository as 200 to 400 milligram per day. Next. Chitrakala next. Chitrakala. Chitrakala. So coming to the ovarian stimulation. Yeah. Physiologic link, developing follicle produces this corpus luteum, better follicular dynamics, theoretically better luteal function, and there is no proven link between poor fertility outcomes and luteal surrogate markers. Ovulation induction is not demonstrated to treat LPD. So ovulation induction is not needed per se. So proven benefit after fertility treatment, no evidence of benefit in natural cycles or for treating LPD. So there is no randomized control trial for progesterone in women with LPD. Mixed results are there for recurrent pregnancy loss. Next. So no effect when started post-positive pregnancy test. So findings may not be applicable to LPD cases when the pregnancy test becomes positive. So what is the future? The LPD proposed as a cause of infertility and early pregnancy loss over 70 years. There is a lack of quality research on definition, diagnosis, and treatment. Controversy exists outside of known pathologic conditions affecting LH pulsatility. So next, research is needed, determining if isolated LPD truly causes infertility and develop validated diagnostic tests to differentiate fertile versus infertile women with LPD. Conduct RCTs evaluating therapeutic options in proven LPD. Next. So to conclude, present data do not support LPD as a clinical entity causing infertility or early pregnancy loss. There is no proven treatment which improves outcomes. Next. But clinical LPD, that is luteal phase less than or equal to 10 days, abnormal luteal function can result from various medical conditions. So true isolated LPD, where there is abnormal luteal function without identifiable systemic disease affecting LH support of the corpus luteum. Next. So in this, evaluate any underlying medical condition which I have mentioned and do not recommend histologic endometrial dating for diagnosis. Further research is needed, like combined testing like luteal progesterone, luteal phase length less than 10 days can identify women at higher risk of poor predictive outcomes. They show benefit from targeted treatment. Next. So the controversies and future direction, it's a distinct pathology or a physiologic variant is again a question. Novel biomarkers like integrins, transcriptomics for endometrial receptivities are studied. Time-lapse luteal hormonal profiling, role of personalized luteal support in ART. Next. So the take-home message is LPD is well-defined in assisted reproductive techniques, poorly defined in natural cycle. There is no gold standard test which can diagnose in natural cycle is controversial. ART cycles require luteal support with progesterone or a combined estrogen progesterone or HCG. Natural cycle treat only with specific indications. Research is evolving, avoid overdiagnosis. Next. Thank you for your patient listening. And this is the only take-home message to understand our physiology, to identify the pathophysiology. That is the hormones, anterior pituitary, and the ovulation cycle. Thank you.
Thank you so much for such an elaborative talk, ma'am. Richa ma'am, for your comments, ma'am.
Yeah, she has very nicely presented the causes and how to diagnose and then the treatment. But overall, we need more research because unless like empirically progesterone is being given, be it dydrogesterone or micronized progesterone for the luteal phase support, but most of the times without any clear-cut diagnostic criteria on empirical basis. So we have to find out more ways to diagnose it so that if progesterone is being given, it is for proper indications so that it helps the patient also. So we need to work more on the diagnostic criteria.
Thank you, madam. References are from ASRM 2021 committee opinion and also the dydrogesterone paper, which is released in 2023, madam. 2025, no evidence per se. Thank you, madam.
Thank you, ma'am. So as of now, no questions in the chat box. So we'll move on to our second session. So we have a very interesting panel on recurrent pregnancy loss, was moderated by none other than our very own Dr. Jairani Kamaraj ma'am. It's such a pleasure and privilege to introduce ma'am, who's an eminent personality. And she's also, ma'am has numerous credentials to her name. She's the immediate past president of Oxy, and currently she's the vice president of Tapizar, joint secretary of TNFOG, and she's also the she was the joint organizing secretary of ISA 2015 and member board of studies of Tamil Nadu Dr. MGR Medical University. And ma'am is Southern coordinator of No to Violence Against Women Committee of Foxy. She's received various awards like the Best
Thank
Doctor
you.
Award.
Thank you, Madhu. Thank
And
you. Thank you
yes,
so much. We'll move to the panel.
yes,
Yeah.
yes. So we have our eminent panelists here, Dr. Nirmala Pandey, who's a senior gynecologist, and currently she's practicing at Ajmer. We have Dr. Ruchika, who's the secretary of Ajmer Obstetric and Gynecological Society. Dr. Aprajita, who's the assistant professor at Madhubani. And next slide, please. We have Dr. Jaimina, who's the assistant professor at Sri Muthukumaran Medical College at Chennai. Dr. Richa Singh, who's the president of Agra Obstetric and Gynecological Society. Dr. Manisha Maheshwari, who's now the consultant at Heritage Hospital, and who's ex-assistant professor at Firozabad Government Medical College. Dr. Josephine Joshi, who's the HOD of OG at Mada Medical College and Hospital at Chennai. Dr. Richa Raj, who's a consultant at Srijan Clinic. Dr. Radhika Gauri, who's the consultant at ESIC Hospital at Tirunelveli. Dr. Akansha Gupta, who's associate professor at SN Medical College in Agra. Over to you, ma'am.
Thank you, Madhu, for that lovely introduction. And a very special thanks to the dynamic leader of this Pinnacle series, Dr. Sampath Kumari, and a very special thanks to all the senior Foxians from UP, from all the East, West, from Ajmer, from Sultanpur and Darbhanga, and from my own Oxy. A very special thanks to one and all. And we are here to talk on a very, very important problem, what we see in the clinical practice as a practicing OBGYNs, because many a times the more disgusting problem that we encounter is a miscarriage which is happening in a women, and we are almost have to have a lot of patience, passion, and also perseverance in finding out the cause, treat the cause, and give her a healthy baby. And it is always a stressful moment for every one of us here, that when we come across a recurrent pregnancy loss, which is really a troublesome and stressful one for each one of us in our clinical practice. So we are here to talk about RPL. It needs ages, because if you call upon Dr. Mala Arora, if you can tell her, madam, we want to talk about panel, she will say, is it possible? So in that way, this RPL is now gaining lot of inputs and insights, as rightly pointed out by Dr. our guest of honor, to talk about this, all the genetic problems as well as the molecular level of this RPL. Now, lot of insights are being thrown into what causes this and how we can manage, what are the immunological system which getting affected, how we are going to have the immune modulation, because we know pretty well the parental origin of this antigen which comes into the uterus of a woman shows thought of immunological response, which is the women has a way to tackle this antigenic response in such a way that this acceptance of this immune system through its modulation is a very beauty of this pregnancy being happening with a healthy child. So there is a lot of things play a role in having a healthy pregnancy. So we are here to show a light of a practical approach, how you are going to approach with a RPL case when it happens in your clinical practice. What are the common things will you look into it? What are the etiological causes and how you are going to manage? To throw a lot of insight, we have our eminent and very senior panelists here from all over the country to talk about it. And I'll be really happy if each one of you share your thought from either by the evidence as by your clinical experience, and also you can even throw a lot of insights of what is prevailing in your part of the country, so that it is easy for everyone who watches this to take home a good message, so that when they come across an RPL patient, how they can manage will be a real thing. So can I share my screen, Shakti?
Yes, ma'am.
Can you see
Yes, ma'am.
my slide?
Yes, ma'am. Yes, ma'am.
It's full screen, Madhu?
Yes, ma'am.
Okay. So I think we'll start. Is my slides moving? Yeah. So I would like to thank all the panelists here with all of your answers, because we have to first define what is an RPL, because there are a lot of questions which happen in a clinical practice that if they come with one loss, are we justified to manage them? Or if they come with two losses, is it a standard practice to treat them? So we should know what is the definition. May I start with the senior madam, Dr. Nirmala madam? Can you tell me how you define RPL? Can you tell me the definition of RPL? Is madam is here? So anybody can take this question.
So, ma'am, may I answer?
Yeah, please.
Ma'am, so there are different criteria from the different bodies which define RPL. So the latest ESHRI guideline 2022, which says that if there is a loss of 2 or more pregnancy before 24 weeks of the gestations, but it excludes ectopic pregnancy as well as molar pregnancy. However, ASRM has defined also 2 or more losses of pregnancy, but the pregnancy should be confirmed with ultrasonography or histopathology. However, RCOG defined that if there is a losses of 3 or more consecutive losses of pregnancy before the period of the viability.
Your voice is breaking. Hello. Can you hear me, Madhu?
Yes, ma'am. You're
But
clear,
I think if someone can.
Aprajita, you're muted, I think. Dr. Aprajita, I think you're
Yeah.
muted.
I would request all the panelists to unmute them so that whenever you have an answer, you can just. Dr. Aprajita, you are answering. Continue.
And panelists, can you just, if your name is not there, if it's just as doctor faculty, please rename yourself.
Okay. So by definition, it is a number, how many weeks, and of course, whether it could be a consecutive or it could be a random. These are all the criteria that the guidelines says to define the RPL, by which, as rightly pointed out by my panelist, that the ESHRI criteria, they say up to 24 weeks, and that has to be proved either by a serum or a urinary HCG, and it should not include ectopic and the molar pregnancy. That's what is given in ESHRI. But ASRM, 2 pregnancy, and it should be defined by ultrasound or by histological examination. By RCOG, they have given all inclusive, but it is 3 and more. So these are all the very important definitions by the standard guidelines which has been given by the societies. And if you look at the Chinese and UK, that is little different, and they also has more or less in congruence with the ESHRI and ASR. So we have to define, when a woman comes with one loss, it is always us to encourage her, give her a good positive support, and then if possible give her a positive support and give her and wait. And if she comes with 2 losses, it is better we do. And can anyone tell me what is our FOXY guidelines? FOXY guidelines says about RPL. Any one of my panelists? Yes, Richa? Ruchika? Okay, so FOXY says 2 or more with a confirmed with ultrasound or by histopathological to say as a RPL. So that is what the FOXY guideline says. So can anyone tell me what are the different types of RPLs when you come across in your clinical practice? Can I ask Dr. Jaimina? Can you answer? Are you in?
Yes, ma'am.
Yeah, please,
Ma'am,
please.
there is actually a primary RPL which occurs when there is no pregnancy before. The couple has not had any pregnancy before. But a secondary RPL which occurs after a pregnancy that has reached a viability, which is around 20 or 24 weeks according to some guidelines. And there's also a tertiary RPL, which is occurring in between pregnancy, ma'am. So it has to be noted that this pregnancy has to cross the period of viability.
Yeah, they can even have a healthy pregnancy in between also. That also is coming under tertiary loss. So these are the three important categories. Because why it is very important, can anyone tell me? What is its importance? Are we happy with the primary or secondary or tertiary? Which one you are very happy?
With the tertiary or the secondary, ma'am.
Yeah, because they have a healthy child. So they have all the chances to get a healthy child. But all the more, in a primary, there is a risk of getting it again and again. But when they are in the secondary and tertiary, you are little confident of giving her a healthy baby. So that is why the primary tertiary plays a role in categorizing the outcome of this RPL management. So next, coming to how prevalent, I think you all know the prevalence. If anybody can say that to have a completion about the prevalence of RPL in your setup or in our country, rather in the Indian setup. So they've given in a primary, it's up to 75% of cases in Indian scenario, because there's a study by Indian Study, Singh et al. They have found out the distribution of RPL according to the trimester. They have given from the patient, it's 1 in 300 pregnancy who have RPL, and 2 to 5% of the couple go through an RPL. So RPL is almost up to 2 to 5%. And in our clinical practice, nowadays we come across more of RPL, mainly because of the age-related pregnancy loss. Because we know pretty well elder women taking up the pregnancies, it is always important that they get the miscarriage rate very high because of age. That is also playing a very important role. So now coming up to the causes for the RPL. So may I ask Josephine or Manisha? Manisha, if she's here, she can take up the question.
Ma'am.
You can
Yes,
take
ma'am.
up this question. What are all the commonest etiological causes when you talk about RPL, you will keep in mind? When a woman comes to you, what are all the things that you will keep in mind? Unless otherwise you know the cause, you can't treat her. So what are the causes that you pretty well plan? I mean, we will plan to evaluate, and how you're going to find out, and what are the things that comes into your mind in an RPL?
Ma'am, etiology of RPL, may 40 to 50% are unexplained. Majority of them are unexplained. Then come the autoimmune factors, which include APS. And then comes the endocrine factors such as uncontrolled diabetes, uncontrolled hypothyroidism, etc. And then are the uterine anatomical factors, which may be congenital as well as acquired. And then is the 2 to 5% is about genetic factors. And then the last is the infective pathology. Another less important may be immunological factors, other hormonals, and male factors, environmental factors. They may be toxins, they may be the other factors.
Yeah. So I think you have given a very clear idea that most of the RPL are unexplained. We can't find out any reason. That's why many a times they come for you for repeated treatment, and after 4-5 losses, suddenly they come with a healthy pregnancy. So this all can happen when a woman go through an RPL. So that is why we have to know that 50% it is an unexplained or we don't know what is the reason. And very interestingly, the treatable causes which we must know is the immunological causes and the endocrine system, because these two things will play around 30 to 40%. So in that way, categorization regarding underlying etiology can give you a positive hope that there are some treatment available for this patient so that they can have a healthy pregnancy. And anatomical, we all know it is only a mid-trimester loss. So in that way, almost 40% is a identifiable cause, either in the form of an endocrine problem or an immunological problem. So in that way, finding out the etiology is very, very important. And very interestingly, nowadays we come across a lot of miscarriages because of increasing age of the women of the pregnancy. She takes up the pregnancy very late. She get married very late. Automatically, there is an increased risk. When she's above 35, she has a risk of 25 to 28% to get a pregnancy loss because of the chromosomal aneuploidies, which is quite commonly seen in her. And all the more when it's above 40, it's almost 51%. So the risk of miscarriage among the elderly couple is very high. So always age plays a very important role. And very interestingly, can anyone say about the lifestyle factors which also nowadays play a role in etiological causes?
Ma'am,
I think,
it
yeah,
increases with the increase in
Yeah,
age, with smoking, with obesity, with caffeine use,
yeah,
with the use of caffeine, with smoking, with drinking, there's increased risk with increased BMI of the patients.
you are very correct. Yes, these are all something also we have to keep in mind when we are treating her, because we'll be investigating with so many things. But underlying these factors, lifestyle factors, we must keep in mind, because nowadays smoking, drinking, all the habitual use of a lot of drugs, everything is quite common among youngsters, which also could be a reason for their repeated miscarriages, and also about the age. So this is very important that you have to keep in mind when you are evaluating any women with RPL. So now coming to an approach. So now we have one patient who is having a treatable problem like the APL. So can anyone tell me what is the definition of the APL, or what do you know about APL, and how you can, what are the things that you want to know about it? Can anyone tell me, either Josephine or Radhika? Radhika, you are here. Can you talk about APL? What is the APL condition which you look into it? And how is it when you're diagnosing with an APL? How you're going to look into this patient? Manisha or Richa? Richa is there?
Ma'am,
Yeah.
yeah, ma'am. Ma'am, APL is the most common treatable cause of a recurrent pregnancy loss.
Yes.
And normal population has 5% incidence of APL, while in patients with RPL, it reaches up to 15%. Now,
Correct.
APL is a condition where antibodies are developed, mainly lupus anticoagulant, anticardiolipin antibodies, and beta 2 glycoprotein
You're
1
right.
antibody. And there are definite clinical criteria as well as lab criteria for its diagnosis. Among the clinical criteria, one should fulfill one of the clinical, one of the lab criteria. Clinical criteria consist of either one confirmed episode of any thrombotic event, venous, arterial, or microvascular, or a poor obstetrical outcome in the form of one or more pregnancy loss of more than 10 weeks of gestation with a structurally normal fetus, or a premature baby born before 34 weeks of gestation, who is morphologically normal, either due to severe preeclampsia or any vascular insufficiency, or a history of 3 or more recurrent abortions. Uh, that comprises of clinical criteria, and among the lab criteria, increased plasma levels of lupus anticoagulant, or increased IgM or IgG antibodies, anticardiolipin, and increased IgM antibodies of beta 2 glycoprotein. And these tests should be done on at least 2 occasions and at least 12 weeks apart, and preferably 6 weeks after the pregnancy loss. So if these criteria are met, then the patient is diagnosed as APS.
Absolutely. Very proper, very proper. Anybody want to add up anything? I think Manisha has given a very clear picture of the APL, how we have to diagnose, what are the clinical criteria, what are the laboratory criteria, what are the history criteria. We have to look into this women, because many a times the APLA is, as it is, gestational APLA, which is very commonly nowadays seen as pregnancy APLA. And also there are some underlying problem which can trigger this immunological system, especially when they have a previous history of vascular thrombosis, or even a previous history of preterm labor, preterm birth. We have to keep in mind that this women can have a cause underlying, mainly than APLA, which may predispose her to get this problem. So we can focus our investigation pertaining to the history. From all this history, we can find out the cause so that we can look into those details to treat her. And definitely, there are two types of APLA, which can be a primary or secondary. The primary, there won't be any underlying disease. This is what we call as a pregnancy APLA, where they have only an APLA during the pregnancy. They don't have any other problem. But secondary, it may be an associated with other conditions. Either could be a previous vascular disease or any other disease which she have developed. Because of that, she is getting into the APLA. So these are two important things we have to understand. But the basic problem in this women is mainly the target, which is the trophoblast. So the APL will act on the trophoblastic invasion properties, and thereby there can be an impaired trophoblastic invasion and also inappropriate secretion of the HCG and the growth factors, which causes a problem in the functioning capacity of the trophoblastic problem, causing lot of apoptosis in the sensitive trophoblast, and also causes a lot of inflammatory response through the complement activation on the fetal maternal interface. And this is the main reason that they have a problem in the vascular endothelium, causing an abnormal formation in the spiral arteries. Thereby, it may cause an early miscarriage or an early PIH or a severe PIH or a preterm labor or a preterm birth. So the basic problem is in the placental vasculature, which is the main thing, which can either happen as a primary or secondary. So that is the one thing. Then a word about the genetic factors. Though this may form only 1 to 2%, but still, I would like to ask my panelists, if they come across a woman with the miscarriage, recurrent miscarriage, second time she's coming, with the pregnancy loss, with the miscarriage, will you ask her to go for any other test during that pregnancy, or when you want to, when she's come with the pregnancy, will you advise her to go for any genetic testing? Does it play a role, and what is the role of this product of conception
Ma'am,
assessment? Yeah.
second trimester loss, we'll go for chromosomal analysis.
Yeah.
If they're repeated if there is even one second trimester loss.
Yes, yes. So many a times the pregnancy loss could be a genetic factor. So we have to look into what are all the genetic factors. Will you look into this couple when they come to you with a recurrent pregnancy loss? In between, if they are coming in the interval phase. What are the genetical tests which you advise to the couple? May I ask?
Yes, ma'am.
Yeah,
Ma'am, may
yeah,
I?
please. Yeah, please,
Yeah,
Richa.
ma'am. Good evening, ma'am.
Good evening.
Ma'am, we would suggest karyotyping and or microarray.
Yes,
Now,
you're
new
very
tests
correct.
are also available, like next generation screening,
Yes,
gene screening.
yeah, good. So when a couple comes to you, we always look into the karyotyping. If she's pregnant now, the woman is pregnant, we can even send the product of conception for the microarray test to find out the chromosomal aberrations and also the translocations, which can give us an idea of two things. One is to do a genetic counseling to advise about the next pregnancy, and you can have a plan for her when she plans for the next pregnancy, so that this genetic factors, if they are proved that this women have, either she has a karyotyping, have a balanced translocation or a normal variant reciprocal translocation, then you have to keep in mind how you're going to plan her pregnancy. That is why it plays a role. So very importantly this. And is there any other test will you advise for the father or the husband, Richa? So you said about the women.
Yes, ma'am.
And the
Yes,
product of
ma'am.
conception.
DNA fragmentation.
Yeah.
Ma'am. DNA fragmentation test of the sperm.
Yes. So more than 3 losses, the one important thing we have to rule out is the sperm DNA fragmentation. So DNA fragmentation is only used in this RPL cases only, because 10% of DNA fragmentation men have they are very much the reason or the cause or the etiological causes for the RPL. So this important thing which you should know about the process. And about the POC, will you advise the POC? I think Richa has answered. Yes, If the POC, if you take up the POC and if you find a monosomy, what is your information from them? How you are going to talk to the patient? So if the POC is a monosomy 45X, then how you are going to plan? What is the thing that you are going to carry in her? Can anyone talk? Josephine? Okay. So if
It
the
may be a random
yeah.
event.
Yes,
It may be
please.
a random event because it is the numerical structural abnormality, and it may be a random event, and the prognosis in future pregnancies is very well. And we
Yes.
need not do further workup for this patient.
Absolutely, you are very correct. If it is a euploid, then we can forget about the chromosomal problem. We can look into the other causes why she has aborted. That is a very important thing which we can keep in mind. So the chance of this recurrence will be very less. That is a very important. Only in case of a if you have any other problem like the chromosomal translocation or inversion, and then you have to order for a parental karyotype. That is very important, because if they have a parental karyotype abnormality, they are a high risk of developing chromosomal translocation or unbalanced translocation or inversion. So this is a very important step. For them only you will advise other genetic testing as well as the screening. So next comes to the importance. So we are now one part, we are known about the immunological system, and now we are going to talk about the unexplained, which forms a major part of the etiological causes. Can anyone elaborate me in unexplained what are all the things that you will investigate, and what is the chance of this unexplained getting again an RPL, and how you are going to approach this patient? Yes. Is there anyone who can, Abhirajita? Meena?
Actually, unexplained infertility accounts for about 50%. The chance of them getting a successful pregnancy is around 70%, ma'am. Because with further pregnancy loss, the chance of pregnancy does increase.
Yes.
But if no cause has been found, then we can continue the same line of treatment, and immunoglobulins can be given, although no studies are there regarding the use of them in unexplained RPL. They can be tried, and pregnancy can be achieved with that, ma'am. But
Yes.
the other causes like diabetes, hypothyroidism, the genetic factors, all has to be ruled out for the immunoglobulins to be tried, ma'am.
Anybody want to add up anything? Say as it is in this.
Ma'am, methyl.
Yeah, please.
Methyl tetrahydrofolate phase, that mutation, that also we have to rule out. MTHFR gene mutation. That we have to rule out. And one approach that we all follow, that tender, loving care approach, that is a must for unexplained.
Yeah. So here comes your role of your MTHR. I mean, this is something that we have to keep in mind. The polymorphism of this can cause a recurrent miscarriage. So the simple treatment with your folic acid and B12 will help to improve the chances of getting a healthy pregnancy. And also you must keep in mind about the what our chief guest of honor said about the TH helper cell. So because nowadays the main unexplained idiopathic conditions, we treat them empirically with progesterone. So the progesterone plays a role in the immunomodulation. It is that play a very important role in unexplained infertility, because the immune tolerance in the maternal system getting variability, and that is the reason that many a time it rejects the embryo. So here comes the immunomodulation through your progesterone. Either it could be a micronized, or it could be a your dydrogesterone, which play a very important role in this helper cell activity improvement, and thereby there can be a better chance of implantation and sustainment of the pregnancy. So there is a very important one. So another factor, yes, some I think Richard told about the tender loving care, because the psychological factors also play a role, as and also the environmental factors also, they also play a very important role. That is why we have to keep in mind all this system, that the psychological system has a role, the fear, the anxiety, the depression and fear about, because once if they lose, the next pregnancy will become a nightmare. So they will not have the happiness of the pregnancy, but they will be always having the worry of whether I can take this baby in a better, in a healthier way. That will be the anxiety, and they have a miscarriage because of this anxiety itself. So definitely psychological factors play a role. That's why a tender loving care is a very important step that we should adopt for this type of a patients. So about the infective causes, yeah. So here comes the environmental and psychological factors like caffeine, alcohol, and also depression, guilt, anxiety, and anger towards, they also play a very important role. So word about the uterine causes, especially infection. Can anyone say about the infections, how it can cause a RPL?
It will prevent endometrial receptivity will be impaired in all those cases, ma'am. So chronic infections like all those mycoplasma and ureaplasma ureolyticum will cause all those problems.
Yeah. So definitely there are a lot of infections, and in addition, the men having a papillomavirus HPV infection can also cause an idiopathic pregnancy loss. There have been a lot of studies from the men having a HPV infection can also cause for a can be a leading cause for the IPL, recurrent RPL in these conditions because of this HPV infection. So endometritis, like chronic infections like bacterial vaginosis, especially mycoplasma hominis and the uroplasma urolyticum, always cause a lot of problem related to the RPL, because we don't nowadays look into TORCH at all. TORCH infection is ruled out for RPL. We don't investigate regarding TORCH for RPL. But this chronic infections like mycoplasma, uroplasma urolyticum, they are the one which can lead on to many such conditions, because there have been a lot of studies which proved in couples with even a lot of patients with celiac disease and chronic infectious diarrheal cases, they have a higher incidence of RPL, because they found out in their endometrial level the bacterial population is very high, causing miscarriages, and that has been proved by a lot of studies. They have found out the spectrum of endometrial microbiome. The microbiome from the endometrial fluid has been studied in plenty, and nowadays the same factors what we see in an RPL is almost like an RIF. As a fertility specialist in recurrent implantation failure, we also look into all these causes because they are all interconnected. If they don't implant, if they implant, they may go for miscarriage, and this is also one reasons why they go for a RIF. So all these things are very important. A word about uterine anomalies. Can anyone tell me what is about the uterine anomalies causing an RPL? Josephine?
May I?
Yeah, please, Richa.
Yeah. Ma'am, uterine anomalies can be either congenital or acquired. The congenital can be either uterine septum or bicornuate uterus. There are different types of anomalies, congenital, and acquired can be a synecdoche or a fibroid or a polyp.
Yes. So coming next to these are all the common causes which can cause a mid-trimestral loss, either in the form of a cervical incompetence or a preterm birth or a PROM, which are the commonest causes for this type of either a uniconvate uterus or a biconvate with having a cervical incompetence could be the reasons. So these are all something we have to keep in mind when women come with repeated recurrent mid-trimestral loss. A very important step that we have to look into the anatomy, 3D ultrasound, and also even needed an MRI or a hysteroscopy to find out any other causes which may predispose her for a second trimestral loss. So this is very important that we have to look into the anatomical factors. So next, coming to the endocrine factors, because this is one important problem which we must not miss in any case with RPL, because it plays an equally important role like your immunological system. This endocrine factors play a role. Can anyone elaborate me what are all the endocrine factors
Ma'am,
you will
uncontrolled
evaluate?
diabetes is one of the major causes of RPL.
Yes.
Uncontrolled thyroid, defects in the prolactin.
Yes.
uncontrolled diabetes.
Yeah,
Even subclinical
PCOS.
hypothyroidism is strongly associated with RPL. And if TSH is more than 2.5, it should be treated. It is recommended that it should be treated. And TPO antibodies should be done to assess the level of autoimmunity against thyroid. And hyperprolactinemia is also associated with recurrent pregnancy loss.
Yes.
Apart from that,
Any other thing?
and
So
PCOS.
Polycystic PCOS, ma'am. PCOS.
yeah, PCOS.
And LPD. LPD. We talked about LPD.
Yeah,
LPD was
LPD is
also
very important. As first talk, we had the LPD. So
Ma'am,
LPD also
insulin
one reason.
resistance also can cause
Pardon?
insulin resistance.
Yes, especially in the PCOS women,
Can,
either through an
yeah.
insulin resistance or insulin resistance per se. The obesity in obese women, this play a role either by the obesity play through insulin resistance or by causing a hormonal impairment or a imbalance causing this PCOS also cause a RPL. So very important, we have to look into all these conditions when you come across any. So these are basic investigations. That's why we do for all this a thyroid assessment, prolactin assessment, your insulin resistant assessment. And very important nowadays with the women increasing age, the elevated FSH and lowered AMH also can be one reason. When the reserve ovarian reserve gets lower, they also can have a risk of having a aneuploid embryos, which could be the reason for their miscarriages too. So elevated levels of FSH, basal FSH and lowered AMH also could be one reason. So when you come across any endocrine system, you have to assess all these tests to find out the cause and then of course causing the problem. So how they play a role? We know hyperprolactinemia causing an alteration in the pituitary ovarian axis and thereby cause an impaired follicular genesis and anovulation causing a RPL. And in thyroid, we know pretty well there is a high incidence of subclinical hypothyroidism. So can anyone tell me how you diagnose a subclinical hypothyroidism?
When the TSH is more than 2.5, and when the free T3 and T4 are within normal limits, we can call it as a subclinical hypothyroidism, ma'am.
Yeah. So what other test will you do when that patient present to you?
Well, we can do an anti-TPO antibody assay to know whether this is what it's involved in RPL, and we can proceed further, ma'am.
Yeah, you're right. So we have to assess the anti-TPO. So this that can give us an idea of whether to treat her or not. If it is high, we must give her thyroid replacement so that it will be helpful for her to sustain the pregnancy. This is one important thing we should keep in mind. Subclinical hypothyroidism is very important reason for recurrent miscarriages, should be treated.
Ma'am,
So as you, yeah.
Ma'am, any role of thyroglobulin antibodies?
Yes,
Any
both thyroglobulin as well as TPO, both
TPO,
have to be looked into it, right? Because thyroglobulin, it is more for the hyperthyroidism. That also can be one reason for causing the miscarriages. That also can be, it should rule out, especially Hashimoto thyroiditis, which can also cause a recurrent miscarriages, should be treated before she conceives. So PCOS, as pointed out by all of you, it can cause either by the hormonal imbalance caused by the insulin resistance or by the hyperandrogenemia, or as it is, it may cause anovulation causing a miscarriage, or it could be because of the abnormal glucose tolerance, because many a times the PCOS will be associated with abnormal glucose tolerance because of the insulin resistance that may predispose her for a RPL, and also they can have a problem with the thyroid also associated with the PCOS. So all this go hand in hand. And LPD, we have a good talk by Meena, entire how she explained everything about LPD. Definitely LPD in a RPL women has to be treated. There is no definite diagnostic criteria for LPD, but we are always justifiable if you give her a progesterone support, even for a natural pregnancy. If she has a ovulation being tracked, we can start the progesterone way from the ovulation. This may give her two things. One is it can give her a proper luteal phase support, and also it can modulate the endometrium
in such a way that the immune modulation is regularized and it's regulated, thereby the implantation is well favored for the pregnancy to continue to grow. So this is also, the progesterones play a very important role. And a word about the insulin resistance, as you've all pointed out, the insulin resistance also play a very important role. And antithyroid antibodies, yes, there have been a lot of studies which state about the antithyroid antibodies. It have a role in its RPL. Then coming to the immune factors, we know the cytokines play a role. Can anyone elaborate about the thrombobilian effect? Causing a, I mean, it's causing RPL. We have talked about it, but still we must know, because many a times even APLA will be negative, but we have to see about the coagulation factors, which are very important, because many a times this thrombophobia can be a very important, play a role in RPL, especially when they come with early onset PIH, early onset preterm birth, IUGR, stillbirth. All these things could be a reason for the inherited thrombobilic effects. So it is very important that we must rule out the coagulation factors, especially prothrombin 2 mutation, factor 12 gene pleomorphism, which play a very important factor 5 leading mutation. They always causing a thrombosis of the vessels, especially the uteroplacental vessels, causing a IUGR and stillbirth. So we have to keep in mind, especially in an unexplained RPL, you have to check all these things. So these are all something about the causative factors. So once we know about the etiological factors, then how we are going to evaluate her. Can anyone, each one can tell me what all the investigations will you do, or one can tell about everything?
Anatomical factors first, if in case you want to roll out, you will do an ultrasound pelvis, ma'am, first to make sure that there are uterine anomalies. In case you are suspecting a uterine anomaly, we have to proceed on with MRI pelvis.
Yes.
Then APLA, definitely we will go in for blood tests. Find out beta 2 glycoprotein 1 antibodies, then anticardiolipin and lupus anticoagulant. Then endocrine abnormality, you'll do serum TSH, free T4 and T3. Then in case you want to find out about genetic causes, we'll try to send products of conception and check out and send the couple for genetic counseling. Otherwise, you can plan for pre-implantation genetic diagnosis. Environmental causes, yes, you can try to eliminate environmental toxins by doing specific environmental diagnosis, environmental products which are present in blood, depending upon your consultation with that specified specialist who deals with environmental. Psychological, whenever there is a psychological cause, yes, you have to advise them to do tender loving care, and then you can promote tender loving care, and then that might click for some patients. Unexplained, you don't have any explanation, or you don't have anything to explain to the patient, so you have to think about giving either progesterone or and immunomodulation. But though there are no evidences say, but you can try giving all those things to continue pregnancy.
Yeah. So when a patient comes, the basic investigations, like starting from your GTT and starting from your platelet count, you have to do all the immunoglobulin, I mean, all your tests related to their RPL. We have to look into this, and this is the recommended investigation for the RPL by the guidelines of RCOG, ASRM, and ESHRE. So they have given, these are the valid tests. Are we justified in doing cytogenetics? To whom we should do, what we should do, when, which are the types of patients that we should do. They have given very nice guidelines. What are the tests that you should look into all these conditions? So as rightly pointed out by Josephine, each one of the investigations we have to do specifically for this patient. So now coming how you're going to manage her. So when a patient lands with APS, what is the drug of choice that you will give for her? So you have a patient with APLA positive. What is the drugs that you can give her in your setup, or any other recommendation?
Definitely low molecular weight heparin, ma'am. along with aspirin definitely will be the standard treatment.
Mm.
Heparin can be either low molecular weight heparin or unfractionated heparin, but in practice we do only give low molecular weight heparin. Dosage will depend upon the body weight of the patient. It can vary somewhere between 5,000 to 7,000 international units twice daily, or it can be given once daily also, but it should be continued after till delivery and after delivery in postpartum also.
Yeah. So, what are the side effects that you shall keep in mind? Because you're going to give her for 12 months. I mean, almost 10 months you're going to give her, and postpartum you're going to give her for another 6 to 8 weeks. Almost 12 months you're going to give for her. So, will you keep in mind certain things in when you are treating her, Josephine?
Yes, ma'am.
Thrombocytopenia and osteopenia.
Osteopenia. Yes, ma'am.
Yeah, that's very important because when you're treating her, keep this in mind. Always give her a good supplementation of calcium and also vitamin D3. Check the vitamin D3 and give her. And of course, the aspirin. So once you have, she is on aspirin, it should be continued. And then even after delivery also should be continued. So these are all very important drugs which are given for APLA. So what about the thrombobilias? What is the line of management if they have a thrombobilia?
Both aspirin and low molecular weight heparin, ma'am. Either you can give either one or you can use it as a combination.
Yeah. So that is a same drug of same line of management. You advise for thrombobilias too. So endocrine factors, I know you can, everyone can say about the hyperprolactinemia. Always treat her. The important of this hyperprolactinemia, this should be started pre-conception. That's very important. You can't treat her post-conception. It is better to start her prior to pregnancy. That will help her for a good pregnancy continuation and sustainment of the pregnancy. And of course, thyroid, you must correct the thyroid before conception and make what are the levels, the standard levels of TSH will you keep in her level to get the pregnancy in a safer way?
2.5.
Yeah. It
Less
should,
than 2.5.
yeah, American Endocrine Society says that less than 2.5, but our Indian FOXY guideline says it's 3, less than 3. That is our guidelines in FOXY guidelines. So we should keep the TSH level well below 3 to give her a good control of the thyroid for a safe pregnancy. Of course, PCOS, we all know the drugs of choice. Yes, anyone, for the completion sake, can anyone tell me what will you do for a PCOS?
Ma'am, first of all, we tell her to have a
Metformin.
lifestyle modification
Yes, very
to
good.
lose
Yeah.
weight. If she reduces 5 to 10% of weight, her cycles will be regular and the chance of conception will increase. Otherwise, we can add on metformin. That's it, ma'am.
Yeah. So very important lifestyle modification, especially BMI reduction, waist hip ratio reduction, central obesity being reduction needed. We can give her metformin, and even your myonestal will help her to reduce the BMI, and you can even plan for the androgen correction if the LH is very high. Correct it. That will help her to have a improved one. And LPD, I think Meena has given a very good way. And management of genetic factors. If there is a balanced translocations or a reciprocal inversion, what is the treatment of choice will you educate for this patient? Is there a role of PGT? Yeah,
I
Meena?
mean, patients with
Yeah.
balance.
Please, Richa, please.
May I?
Yeah, please,
Yeah.
Prajita,
I mean,
please.
patients with balanced translocations, patients should be genetically
Manisha.
counseled. Ma'am, patients should be genetically counseled properly because these patients have a chance of getting 75% chances of having a successful pregnancy.
Yeah.
The gametes produced may be normal, maybe having balanced translocation. In both these cases, she may have a normal pregnancy. And if the gametes are unbalanced, then it may turn into again spontaneous abortion or a congenitally malformed baby. So these patients can be offered IVF along with PGT, or they can go for normal conception along with prenatal testing.
Yeah.
or if it is also not successful, they can go for gamete donation.
Yeah. So the very important thing we should keep in mind is PGTA play a very important role in these patients to go for their own gametes, and we can rule out the chromosomal anomalies before we transfer the embryos. So that is the PGTA role. Unexplained infertility. What is the drug of choice for unexplained infertility?
Progesterone, ma'am.
Progesterone supplementation.
Correct. Yeah.
Progesterone, sir.
So there comes the importance of either the progesterone, which can have an immune modulation, which can helpful, especially your dydrogesterone can play a very important role. A word about the corticosteroids. Where will you use the steroids? Especially when
In
there is a
autoimmune cases, ma'am.
autoimmune,
Autoimmunities.
as well as when there is a NK cell, uterine NK cell changes, which can your prednisolone play a very
Damage
important
the
role, especially in an NK cell activity when it is altered. We use this. So glucocorticoids and the steroids are very much useful in women with NK cell abnormalities. It can be used, and of course, Madam was talking about Manju. Madam was talking about IV lipid and IV immunoglobulin. Yes, for the immune dysregulation, we can use your IV lipid and also immunoglobulin. Though they are very costly, they definitely play a role in unexplained infertility with the causes of that. There is a definite role in an immune dysregulation, and of course in your TNF alpha, which is reportedly involved in fetal loss, mainly causing a lot of inflammatory response in the endometrium through either a tumor necrosis factor. These patients are benefited with your steroid as well as IV lipid, and in the future there's adalimumab, which is a anti-inflammatory response drugs, which we always used in COVID. These drugs also play a role, though they haven't proved the safety in the embryo, but they can be tried. There are some studies which are going on using adalimumab and steroid for RPL, especially unexplained RPL. This can play a role in causing a suppression of the inflammatory response, and thereby that helps for the improvement. So immune dysregulation, definitely all these NK cell, TNF alpha play a role. So we have to keep in mind in resistant cases where everything you treat and correct, but if they fail to continue the pregnancy, you can give a trial with all these drugs. So even a GSF, there have been a lot of studies. There is a multicentric studies which is going on using of GSF, which also causes a lot of changes in the endometrium in the implantation, and thereby they causes a lot of changes in the residual cells, because they found out this GSF is produced by the residual cells, which can causes a positive impact in the trophoblast and causing a anti rejection mechanism, and thereby it helps in this implantation. And of course, in sperm DNA fragmentation, treating in a men also will help for the improvement. And when you come across all the environmental factors like smoking, obesity, passive smoking also play a role. If the partner is smoking, you have to educate them to stop the practice of smoking, and thereby that can help to improve their chances of having a healthy baby. And exposure to chemicals, especially women working in a lot of chemical factories, especially exposed to fertilizers, all these also play a very important endocrine disruption, causing a recurrent pregnancy loss. So always keep a environmental factors also an important one when you look into the women, and we should keep the PGS as a important step. So to summarize, the very important step is evaluate an RPL women from the basic to the advanced. If there is a common problem of your diabetes or a PCOS or your thyroid, correct it before she get the pregnancy. Just advise them once they come with a miscarriage to treat them in between with a proper care, and then plan the pregnancy. That is a very important one. And always keep in mind about the progesterone. It should be given for all the women who have one loss or even RPL to treat them. And they have found out a lot of evidence-based studies to say that the importance of dydrogesterone in improving the implantation and continuing and reducing the success rate. So a word about the endometritis. Yes, somebody can throw a light. Definitely the drug of choice is doxycycline. We must treat with a course of doxycycline and metronidazole for 14 days. And there are a lot of studies which gives very positive impact of this treatment in sustaining the pregnancy, especially in cases with endometritis. And always never forget about the vitamin D, which is also a very important factor which play in the immune system, especially in RPL. So always supplement the vitamin D because that play a very important role in the helper cell mechanism and also the Treg cell, which helps in the implantation and sustainment of the pregnancy. So vitamin D3, always give a supplementation. So these are the recommended testing and the therapeutic managements all in a nutshell. So it is something that you have to take home as a message to treat each causes, what are the treatment clinical testing and what are the therapeutic managements which are advised for this patient. So that is all in a one slide I have put. So with this, I would like to ask each one of my panelists to give one word about the one take-home message about RPL, how you're going to manage her. It's very important. Just give one word. One message.
Couple counseling is mandatory, ma'am. Couple counseling, preconceptional counseling is mandatory. You have to tell them, you have to sit and take your time out and then explain to them in detail, not to worry about what has happened, but something good is going to happen with a very good appropriate counseling is very important, ma'am.
Yeah.
Ma'am,
Very
lifestyle
important couple.
modification and emotional support is very important.
Yes, good. Tender loving care. Yes. Aprajita?
Yeah, ma'am. Yeah, ma'am. Tender loving care actually it starts from the first pregnancy loss itself. The patient when loses pregnancy, even for the first time also, we should do the proper counseling because nowadays we have to assure her that nowadays we can find out the cause. However, it is 40 to 50% still that we are not able to find the cause, but we can find the cause and we can work on it. And there is a probability, much probability that she can be pregnant. So counseling and the care is the most important factor. After that, we will find out the cause and we'll work on that.
Yeah, Meena?
Proper preconceptional testing, ma'am, to find out the cause, and also underlying care is very much important, ma'am, because they have suffers recurrent pregnancy loss. So positive mindset is very important for them, ma'am. So proper workup along with counseling, ma'am.
Okay.
Ma'am, one more thing is HPV factor in the male,
Yeah,
which we generally ignore out.
good. Then anything? So almost all my panelists have given very beautiful words. So I would like to say that RPL is very much treatable. You have to ask the patient to get completely investigated prior to the next pregnancy. Give them, correct all the problems, give them all the supportive care of your folic acid, your B12, your vitamin D3, your calcium and an aspirin, and give her a plan of pregnancy. The planning is important right from the ovulation. Give a progesterone support which will give her a better implantation and better pregnancy continuation, and give her a proper advice about evaluating her gestational diabetes, which can her pregnancy glucose challenge test immediately after the pregnancy. That is very important because any change in the glucose impairment also can cause a RPL. So check, and if they are known thyroid or a hypothyroid, correct it, and immediately after pregnancy you have to alter the dosages, which also should be very important that you have to treat in these patients. So a proper planning is important, and a very tender loving care is the ultimatum, because they still, even after 4 or 5 losses, they can have a good pregnancy with a healthy baby. That also we should keep in mind, because that we have to tell her with no reason. If you lose, you are all the chances to get the pregnancy in a positive way. So this is very important that you have to give it to all your couple who come with this very much stressful RPL. So RPL is treatable and RPL can give a healthy pregnancy. So I thank all the panelists here who are given their lot of ideas and lot of knowledge related to the RPL, and definitely all the delegates would have been benefited from this. I thank all my panelists on behalf of our President Oxy, Dr. Sampath Kumari, and our Secretary, Dr. Meena. And I thank one and all. Yes, a special thanks to the chief guest. Yeah. Oh, Sampath, you are here. Good, good.
There is one question in the chat box. When to give intralipids and GCF dosage? Please answer that.
Madam Jayarani, madam.
Yeah.
Can I ask one question?
Yes, madam. Please, madam.
I'm Dr. Kiran Chandna from Faridabad. Ma'am,
Yes,
you
ma'am.
said to give intralipids, and how to give these intralipids, whether they can be given antenatal in the antenatal periods. And
Yeah, ma'am.
secondly, the question was that you said the before pregnancy also we have to give a progesterone, or we have to start the ecosporin. In general practice, we don't know when the patient is going to conceive. How many times we have to give the progesterone and ecosporin when the patient wants to conceive, and she may conceive and she may not conceive,
Yeah.
and she is very much worried about the pregnancy also, and she does not want that it was a very early pregnancy, and it was a biochemical pregnancy, and all the tests they were not done. Karyotyping of the patient husband and wife done, products of conception, because they were not available, they were not done. But in such cases, patients say that in next pregnancy we should not lose even 5 days pregnancy or 10 days pregnancy. The patients are so much worried in spite of our all counseling. So please.
Yeah, ma'am, as you rightly pointed out, so every pregnancy we cannot monitor the ovulation. Yes, I agree. But especially this RPL women, sometimes when they come to your clinic, you can give them an advice of the post luteal support. That luteal support, you can ask them to take a progesterone, because they may get a pregnancy, they may not get a pregnancy. If they get a pregnancy, it is almost well priored endometrium and your decidua, that is well primed or rather. So because all these immunomodulatory effects play a role after the implantation. The implantation happens after 5 days of your ovulation. So if you can give your progesterone at that time, there is a better chance for the better care. At least tell them, if they miss their period, if they come to you exactly on the missed day, there you can start a progesterone, which definitely have a better role in the endometrium, I mean the decidua. Thereby it can help in the trophoblastic formation and proper immune modulation. This is one thing that you can tell them, because in an RPL patient, they will oblige you. Definitely they will follow with you. And if you don't have a product of conception, which you cannot, you could have, if you are not treating, I mean, if you haven't had a chance to get their product of conception checked in the early pregnancy, you can advise them a karyotyping of the couple and see whether they have any balanced translocation. Because if any one of the couple have a balanced translocation, there is a chance. If they have a normal variant chromosomes, both the couple, then they have a risk of 5 to 10% of getting a mutation, getting an abnormality. So these are all something you can take up for counseling. It is not that you can keep in mind that this woman has a normal variant chromosome at the 19th position, and the men has a problem in the 9th, so they have a chance. So in that way you can have an idea to talk with them, to counsel them. There is a risk. So in that way you can do, even if you don't have a product of conception, you can do a couple karyotyping, and thereby you can give them a counseling. And thirdly, very important is you have to have a proper approach. Like if they have 2 losses, ask them to get them completely evaluated, check the basic parameters of their thyroid, their GTT, everything, and get them corrected. Give them a proper preconceptional folic acid and a control of their diabetes, obesity, their lifestyle factors, their weight reduction, and give them a good, healthy, supportive anemia correction. Everything we can correct them. And then if they plan the pregnancy, they have a better chances. Definitely. That is why sometimes even after 5, 6 miscarriages, they come with a healthy baby. So it can
One of
happen
my
when the
one of my patient, very thin built patient, karyotyping normal, only products of conception not done. Everything is fine. All the tests they are fine. Now she says because every time it was a early pregnancy loss. One time it was 10 days, one time it was 7, 8 days. Uh, one more time also when the gestation sac was in. Otherwise, it was only on the serum beta HCG. Now she says that madam अब तो दोबारा नहीं होना चाहिए. You tell me anything about so that I should not get the recurrent pregnancy loss.
if you feel that everything is normal for her, and if the parental karyotyping everything is okay for her, you can definitely give her the dydrogesterone, as well as you can give her a steroid. This may help in for the, because sometimes it is not possible for us to check for NK cell, your tumor
Yes.
TNF
Yes.
alpha, your protein C and protein S. So empirically giving her a steroid, giving her an IV lipid, which are all only causing a modulation in the immune system, can definitely play an important role in controlling this RPL. That is the
So
one.
these interlipid have
IV
to
lipid,
given.
yeah, IV
No,
lipid
these
you
should be
can give.
given.
It is actually a soya based preparation which is
Yes.
made by the IV lipid. You can give as a intravenous. It is very safe. No
Yes.
problem happens. You can start when the pregnancy is confirmed, so that
Okay.
it can be repeated weekly, one dose. It can go up to 10th week to 11th 12th week.
Yes.
There can be a better implantation once the placenta takes over, and the immune system usually gets settled down by 10 weeks when the placenta takes over. So this
Yes.
can be given up to 12 weeks. They don't have any side effects, but there is not much of a studies, madam. Even in all the guidelines, HRA guidelines, ASRM guidelines, in Canadian guidelines, they say there is no role of all these things has been proved. But definitely in RIF, where I'm using for my recurrent implantation and RPL patients, we always use after 1 or 2 miscarriages, we find out a better pregnancy outcome. So definitely IV lipid, we have a good use. Immunoglobulin is very costly, and it is not that advisable. We don't use much, ma'am. That is not. Steroid and IV lipid are very good, and progesterone. These
What
three
dose of
can be
steroids
you
to be
can use.
given such as what
We
dose
can
of steroids?
we can give
Steroids.
5 milligram, ma'am. 5 milligram, or even 5 to 10 milligram you can give depending on the body weight. If she's thin,
Okay.
you can give her with 5 milligram. If she's obese, you can give her 10 milligram. But please check her glucose challenge test immediately after the
Yes.
pregnancy. We always do immediately on the 31st day. If the UPT is positive, we check her glucose challenge test and a thyroid and thyroid antibodies, and then check if it is there. Then you can start it with the steroid and also with your IV lipid and progesterone.
Ma'am, how
Thank
long
you,
you
Dr.
continue the
Jayarani.
steroids, ma'am?
Wonderful.
Ma'am, how long you continue the steroids and how do you taper the dose?
Till the placenta takes over 12 weeks, 10 to 12 weeks, we give them, and after 10 to 12 weeks, we stop everything.
So do we need to taper?
No need. You can just like that, because it is not going to have any impact. Like she's not immune problem. She don't have any autoimmunity where we have to do it such way, So once the placenta takes over, all your decidua is well formed. So it is automatically, you don't need much.
Thank you, Jayarani. Fantastic.
Thank you, Sampath. Thank you.
Thank you
Thank
for
you
all
so
the
much, Sampath.
panelists.
Thank you, Manju madam. Thank you so much for being
Manju
right till
madam,
the
thank you.
end. It's a real inspiration and blessing for us. Thank you,
Thank you, all
all
of
my
you. Please
panelists,
vote for Dr.
Abhijita.
Jayarani.
Really very, very interesting and very nice. Very, very nice to explain everything.
All President and Secretary Jayarani is contesting for WOW committee. All of you, please vote.
Yes.
Thank
And
you. Thank
for
you.
Richa, for ICOG Governing Council. Okay. Okay, thank you.
Yeah.
Thank you,
Bye-bye.
madam.
We have been doing a
Thank
lot of work in WAR committee. A lot of campaigns we do for the awareness of. So kindly support, ma'am. Support. Thank you, ma'am. Thank you so much. Thank you,
Do it.
everyone. Thank you,
Thank you. Bye.
Sampath.
Thank you, Madhumita.
Thank you, ma'am. So
Madhu,
moving
thank
on
you.
to, thank you, ma'am. Official vote of thanks. So first and foremost, I would like to thank our organizer for the Pinnacle News series, our respected Sampath Kumari ma'am, and the four societies who got together today. The Agra Society, President Dr. Richa and Secretary Dr. Nidhi Bansal, Darbhanga Society, Dr. Kumudini Jan, Dr. Rajshri Purve, and Ajmer Society, Dr. Rama Garg and Dr. Ruchika, and from our very own Oxy, Dr. Sampath Kumari and Meena Mahalingam ma'am. And I thank our respected chief guest, Dr. Hepzibah Kribamani ma'am, for your blessings. Our guests of honor, Dr. Kumudini Jha, Dr. Rama and Dr. Manju Verma, for your kind words and your wishes today. And I thank our chairperson for the first session, Dr. Richa, and our eminent speaker, Dr. Meena Mahalingam, and our vibrant moderator, Dr. Jairani Kamraj ma'am, for the wonderful panel, and our esteemed panelists, Dr. Nirmala, Dr. Ruchika, Dr. Aprajita, Dr. Jaimina, Dr. Richa, Dr. Manisha, Dr. Josephine, Dr. Richa, and Dr. Radhika, and Dr. Akansha. And I would also like to thank our respected delegates for joining us in large numbers today. And the team, Sahiti and Shri Priya, for the smooth running of the program without any technical glitches. Thank you, one and all. Thank you very much.
Thank you,
Thank
Jocelyn.
you, Madhumita,
Thank
for
you, Madhu.
emoji.
Thank you, Madhu.
Thank you, ma'am.